Welcome to our amazing students and future colleagues. My name is Dan Brown and I would like to introduce Clinical Thought of the Week, hashtag the Blogging Tutor. I will only take up a few minutes of your precious time. One of my medical mottos is how we should continue to learn and grow through simple thought-provoking clinical stories. This will help foster lateral thinking and extend our knowledge base. Now relax, take a coffee. This is not a lecture. These are informal glimpses at a range of topics which will leave you pondering. Big disclaimer, do your research to clarify the evidence base for any of the statements I make here today. Question what I say and question what I write. Are you ready? Well, let's take a stroll around this garden pond. Frogging heck, is that a big slimy hand? And how can this humble frog be part of the clinical thought of the week? Well, frogs are amazing creatures. Some are adorned with beautiful colours, some have very impressive vocal sacs, some can actually talk. Despite these wonders of human nature, it's a frog's tongue that is truly special, as you can see. But enough of this nature lesson. What is the clinical relevance here? What could be the relationship between a frog's tongue and foot drop, in this case common peroneal nerve damage caused by trauma? What could be the relationship between a frog's tongue and the most prevalent entrapment neuropathy worldwide, carpal tunnel syndrome? Well, let's find out. The connection is this dashing young man. I do love a bit of historical portrait photography. This is Augustus Volney Waller, a doctor of medicine in the 19th century. Actually, he was born on a farm in Kent, just down the road from me. So what was his contribution to neuroscience? The clue is in his name, Wallerian degeneration. I do hope you've heard of this. Now, Augustus was equally in awe of a frog's tongue, or rather cranial nerve 12. He experimented on numerous frogs by severing the axon of the hypoglossal nerve from its cell body. I say again, frogging heck. He found that the part of the nerve most distal to the insult degenerates. The myelin disintegrates. This retrograde degeneration is known as Wallerian degeneration. Hence, all those beautiful long tongues would waste away. I like to keep it simple with this analogy. If a river gets blocked, everything downstream is in trouble. Moving on from Augustus into the 20th century, a chap called Seddon described 3 basic types of peripheral nerve injury. Now bear with me here, this won't take long. Firstly, neuropraxis, the mildest form, with only a transient nerve conduction block. There will be sensory motor problems distal to the injury, but there is no Wallerian degeneration. Recovery is full and may require days to weeks. Secondly, we have axonotmesis. This is where the axon and myelin sheath is damaged. This is more severe. Examples are nerve damage due to blunt trauma, fractures or dislocations. Finally, we have neurotmesis. This is the most serious, with complete division of the nerve. Surgical intervention is necessary. Now, both axonotmesis and neurotmesis cause Wallerian degeneration. Now, Seddon's classification was expanded upon by Sunderland, who further categorised axonotmesis, but let's not worry about that right now. That's homework. So how does this relate to clinical presentations in practice? Well, examples. Carpal tunnel syndrome, as shown here, a compression of the median nerve is typically classed as neuropraxic, as are most of our common entrapment neuropathies. However, more severe cases of carpal tunnel syndrome could arguably be classed as axonotmesis, and surgical intervention is often required. Peripheral neuropathies are often encountered in practice. They are caused by a range of systemic conditions such as diabetes, resulting in axonal degradation. And of course, flaccid foot drop, in this case direct trauma to the fibula head from a car bumper, caused neurotmesis. These are just a few examples we may be exposed to in clinical practice. Now, research. Clearly, there is still work that needs to be done in understanding how axons become more susceptible to injury. Of particular interest to me is why and how they degenerate with age. I have a patient who walks up the stairs on all fours, not because of arthritis or vertigo, but due to loss of proprioception or feeling in both feet. Another patient who could no longer feel the pedals whilst driving his car, hence the DVLA took away his licence. In both cases, there was no systemic cause, but simply put down to age. Hopefully, further research and drug development will aid prevention and provide therapeutic benefit for such patients. Finally, never forget dear old Augustus Waller and his frogs. Until the next time, it's time to say goodbye. #the Blogging Tutor. Thank you.